Hi, I'm Jay Shubrook, a family physician professor at Troy University, California. And today we're going to talk about team-based care for the person with type 2 diabetes and diabetes kidney disease. And I'm happy to have with me Dr. Katherine Tuttle, who is a professor of medicine at the University of Washington and is uniquely qualified to talk about this topic as both an endocrinologist and a nephrologist who also sees patients with diabetes. So thank you for joining me, Dr. Tuttle.
My pleasure.
This is such a complicated topic now. You know, we have our patients who have multiple conditions, and at least in primary care, I feel like they're seeing many different specialists. And I want to talk about how do we optimize that care. So I'm going to refer a patient to you now who has both diabetes and diabetes kidney disease. And I want to know the optimal ability to assess my patient. What do you want as part of that referral?
Well, I certainly would want a complete medical history, the medication list, and laboratory studies, because in our world, long before there are symptoms or events, the laboratory is the first clue, and particularly albuminuria, a urine albumin to creatinine ratio on a spot specimen is just fine. Morning is preferred, but not necessary. Morning because urine tends to be more concentrated so that the measurement's a bit more reliable at that time of day, but it's not necessary. Just if you can't get it in the morning, just ask them to void into a cup and send it to the lab. And then a serum creatinine, hopefully with an estimated GFR, most labs calculate it. If not, we know how to calculate it. But we're also interested in electrolytes. A lot of people with diabetes develop hyperkalemia early, for example, so I'd like to see a complete set of electrolytes. Also a CBC, because patients with diabetic kidney disease develop anemia sooner than other patients with CKD. So at a minimum, electrolytes, including creatinine for eGFR, a CBC, complete blood count, a urinalysis, because sometimes patients will have clues in the urine of another condition that may not be diabetes, particularly like if there is hematuria or casts in the urine, and then the urine albumin to creatinine ratio. And also, I would like to know what the primary care's expectation is of me. Now, sometimes, you know, when we've been working together a long time, that's understood. But, you know, for this purpose, it might be helpful to know what the ask is. Because in some cases, I find that the primary care physicians are really uncomfortable with the complexity of these patients and they want us to take over management. In other cases, they're experienced in these areas. They would like advice, but they're very comfortable taking the advice, managing the patient, and having us available as a resource for questions or problems.
Okay, that's great. So, you know, when I send a referral, I like to send a year's worth of labs. So I think that rate of change is also important. So make sure you include a CBC, at least a basic, if not a comprehensive metabolic profile, a urinalysis, particularly looking for protein, and then potentially at least a lab note or a letter that says, hey, could you please help with this? And then that gives you the tools to be able to assess what you want to do. What should I expect back after you complete that referral?
Well, what you can expect from me would be a complete evaluation, including my assessment of, first off, is this diabetic kidney disease or not? If it's typical DKD, then treatment recommendations regarding glycemic control, taking into account risk of hypoglycemia balanced against benefits of intensive control for an individual patient. I think, again, in this day and age, now that we're moving to specific glycemic therapies that have kidney and cardiovascular protection, perhaps a recommendation regarding which one of those would be preferred for an individual patient. With regard to blood pressure, a blood pressure goal, and optimal recommendations for optimal use of an ACE or an ARB, but not both, again. Then if there are any other complications developing, including hyperkalemia, bone and mineral metabolism disorders, or anemia, then my recommendations on those, and then sort of your choice. If I find those things, are you comfortable with me making recommendations and you managing and following the patient with me as your resource, or do you want me to take over that stuff? So it should be iterative. I would see it as you volley to me, I volley back. We might be done, but I may have questions for you, and you may have additional questions for me. So I sort of see the relationship in this team sport as being an ongoing conversation between us about the patient. How people communicate, of course, is going to vary across settings. If we have a shared electronic record, maybe we're messaging each other. We might be calling each other. We might be talking to each other in the hallway. I don't think it really matters as long as you find an effective way to be in touch with the people that you're working with. And the other thing that I often find too is we're all attached to our electronic tools, but sometimes I get caught in sort of this ongoing email or message trail where after a while it's not clear to me what's going on, or we're talking about different things. I just pick up the phone and call people then. And it's amazing how quickly you can resolve complicated issues with a conversation and get a common understanding about what's going on.
Going back to our old tools, right? Sometimes we're
old school. Talk when all else fails. Talk to the patient. Talk to the doctor.
Yeah. Well, I think those are really great set of advice. I think it's also complicated when we have multiple specialists. So as I think of some patients that we might be sharing, you know, I might have a cardiologist involved.
Yes.
So if we have a cardiologist and a nephrologist, how do I triage between them? And some of that I just have to do as the primary care provider, but sometimes your recommendations might affect the cardiologist's recommendations.
Sure. And again, I agree, that does get complicated. I guess I can speak for myself. I try to think globally and look at a whole patient. And so, like, for example, with the newer glucose lowering agents and kidney protection, I try to look at that patient's individual situation. If it's somebody who has, at least to my test of reason, a greater risk of a heart failure event, volume overload, pulmonary edema, I'm thinking more about SGLT2s. If it's somebody who has more of an atherosclerotic risk profile or lower GFR, I'll be thinking about a GLP-1 receptor agonist. But I realize that, you know, again, I'm not working in a silo. This is a team sport. That's where I think you as primary care physician are central, because I'll make that recommendation. But it may be, in your case, you're also going to be saying to the cardiologist, hey, you know, this is the situation. Kathy Tuttle thinks that an SGLT2 might be good for this guy because you've admitted him 3 times with heart failure. What do you think? And I guess that is a role for the primary care physician to really be at point, especially when you're dealing with multiple specialties. And I just try to be cognizant of that and helpful and not be so nephrocentric that I'm not seeing the full picture on the patient, but really integrating it to the whole picture. And again, like you called out, the interface between cardiology and nephrology is becoming ever bigger. And I'm hoping that the cardiologists will be thinking the same way in reverse, you know, what's good for the kidneys as well as the heart.
Well, today you really highlighted some very important things that, you know, as we start to have these patients who have diabetes and atherosclerotic cardiovascular disease and diabetes kidney disease, we're going to have team-based care, and that requires us to have two-way communication, talk regularly to each other, and when all else fails, pick up the phone, and let's just make sure we're doing what's best for our patient. So thank you.
You bet.